All right, let's get started then. Do we have any questions before we begin? Okay. Well, this week we're going to talk about traumatic injuries. We'll start with the brain, and then we'll move down into the spinal cord. Very similar mechanisms here, which are very similar to everything we've already talked about, so there's not a whole lot new. When we talk about brain injuries, here we have the possibility for cognitive disturbances, memory impairments, mood alterations. Spinal cord injuries are going to be restricted to motor and sensory function. And that motor can be your conscious somatic control, and it can also be the non-conscious autonomic control. And those can be affected with brain injury as well. But when you get into the brain, that's where we piece our lives together. And so you can have a greater diversity in your functional impairments with brain injury and with spinal cord injury. And TBIs are also far more common than spinal cord injuries. We'll go over the symptoms of TBIs first, and then we'll talk about mechanisms, which we've already covered. So it'll be a nice little review at the end so we can all feel like we know something. I sent you your Exam 1 regrades. Great work. I like what I read. Exam 2, we'll be back on Wednesday. We're going to have a week to do the regrades. Does that timing work out all right? No major things coming up in other classes? No. Fantastic. All right, then it's settled. Okay. So depending on the severity and the location of the injury, that's going to determine what impairments you have. They can be sensory, they can be motor. They can deal with thought, problem solving, so they can be cognitive. As you move down into the brainstem, then we can affect vital signs, and that's when prognosis becomes important at that point. Just like what we talked about previously, when you affect the brainstem, this is when you have a greater risk of dying. Brainstem controls vital functions. Now, when we look across time, TBIs are becoming more common as a group. So there's a few lines to make sense of here. Deaths are in green. Total TBIs are in purple. You can see that closely follows just the emergency department visits because those are the far most common outcome. Some TBIs will be a little more severe and cause hospitalization, and then an even smaller subset will be severe enough to cause death. Now, death is over here on the right axis, everything else on the left. So you can see there are far fewer deaths than there are hospitalizations than there are emergency department visits. When we look across time, this is from 2001 to 2010. This is 2013 data. The prevalence of TBIs as a group has increased, but mostly this is an increase in emergency department visits, not deaths. Deaths have fallen recently, unless you are above 55. Anyone older than 55, deaths are still increasing. Life gets a lot harder as you age, and this graph shows that pretty well. So there's three different lines. Again, emergency department visits, hospitalization. Those are shown in the shades of blue, so they're on this blue left axis. Deaths, red, over here on the right. Notice the different scale. All right. As you're very, very young, you tend to have mostly just emergency department visits, not so many deaths. This shifts, though, as you get older. The elderly account for the majority of TBI-related deaths, as well as hospitalizations. You have that middle blue bar there. So being older and having a TBI indicates poor prognosis. Now, the cause of death varies depending on the age group. The youngest are the most vulnerable to assault for the most part. It's going to be shaky baby syndrome. That's a TBI, and so that accounts for the majority of deaths there. That'd be considered assault. Motor vehicle accidents right below that. Nothing self-inflicted, no falls. Fall down a lot, not a TBI. Over here, get a little bit older, then it's mostly motor vehicle accidents. Self-inflicted TBIs are going to account for the majority of deaths in older adults. And then as you get into the most advanced age group, falls. Notice the difference in scale. Falls are undoubtedly the most common cause of TBIs. They don't always result in death until you get old. Once you get old, then we can see there's a greater number of TBI-related deaths than in other age groups. But falls are going to be the most common cause of TBI, followed by accidental blows to the head, and then motor vehicle accidents. Everything else is fairly low. Even the self-inflicted. I know it seems like there's a lot of self-inflicted wounds. They are usually lethal, so they're going to account for that really small slice of the pie here, the deaths. You usually don't just go for an emergency department visit with self-inflicted TBI. Now, not every TBI is lethal, of course. You already saw that. Some of them are very mild in nature. It would be a concussion. With concussion, this is going to be a hopefully transient change in attention, cognition. Typically, you're going to have a headache. This is common for a traumatic brain injury that usually involves a blow to the head that can cause headache. There's typically some impairment in cognition. It shouldn't be coma. It should just be a little disorientation. Dizziness, nausea, vomiting, these are always related. They can often happen with brain injury. Now, there's no gold standard for saying when someone has concussion and when that concussion has resolved. So you have to have some sort of baseline measurement in cognitive function. Some normal score or whatever cognitive battery you've chosen to use. So that this way you can track over time. Here's just an example. Concussion on 8/23, test 2 days later. Notice we're looking at really a change score here is what we want to see. There's a decrease in memory, whether it's verbal or visual. Reaction time, much slower. This is typical. So you want to see the resolution of these abnormalities. That's when you're going to have an idea of when the concussion has resolved. It's very difficult to say with 100% certainty unless you have a baseline measurement to say, yes, they've come back to normal. Their memory is restored, reaction time is there, they can solve problems. Yeah.
I don't know if this makes sense, but does the baseline have to be updated? Like, do they have to redo their baseline every so often?
It would depend on the age. You would hope that if you're dealing with an adult, they're fairly stable. But yeah, I mean, you wouldn't want it to sit around for a decade or something like that.
Is there like a standard?
Especially, I don't think there's any standard protocol here. But certainly routine testing, it does take time. But if you're dealing with children, that's going to change pretty dramatically. So that's really important to keep updated. Now, the symptoms that occur depend on really the location and severity of injury. Just like with stroke or tumor, location matters. A common feature, though, is going to be this amnesia. Around the time of injury, TBI patients will often forget the injury itself, moments leading up to it, and then some period of time afterward. So there's a loss of memory beforehand that may be retrograde, and then anterograde after the injury. These occur whenever you have disturbance of hippocampal function. The hippocampus is where we keep track of our autobiographical memories. It's also very excitable, so it's prone to injury. And so when you have a TBI, you sort of wipe out the transient memories that are held there because the hippocampus is so excitable. And of course, neurons get excited by injury. It could be mechanical compression, or there could be downstream secondary mechanisms, but let's not talk about that yet. That's the second main point. I don't want to get ahead of myself. Aside from the memory impairments, pain. Obviously in the head and neck, if you have a head injury, you're going to have some pain there. That's totally normal. But what's not normal would be prolonged chronic pain that's not related to any sort of peripheral damage. Neuropathic pain is what we're talking about here. So everything is relative. Hot, cold, left, right, believe it or not. We make these distinctions in our nervous system by comparing two things. Have you ever seen those illusions where they kind of spin around and then you look at some text and it flies everywhere? Motion. We determine motion by just simply comparing. We have neurons that are sensitive to left, neurons that are sensitive to right. What's their balance? Are they equal? No movement. Right's more active, it's moving to the right. So you can exhaust certain neurons, and that can alter your visual perception in the case of those illusions. Or you can go outside and have your hands get really cold and put them under room temperature water so it's hot. That's because your cold, hot balance is thrown off. You exhaust your cold neurons. That's transient. Whenever you have injury to a sensory pathway, that's not going to be transient. But what we're talking about here is not the balance of hot and cold, but the balance of painful and non-painful sensation. So when you have damage to sensory pathways, it is not uncommon to have chronic pain afterward, because we're always making a comparison. Does this hurt? Well, it depends. What's the balance of painful and non-painful sensation? If my painful sensation outweighs non-painful, I will feel pain. It doesn't matter if I actually have any sort of noxious stimulus. It's all about that relative comparison. So in a TBI that affects sensory function, it's not uncommon to see neuropathic pain. Most commonly, this is going to be caused by damage to the thalamus, or input to the thalamus. So here we have our anterolateral pathway. We'll talk about this next semester in more detail, but we have our primary nociceptive neuron, makes the synapse in the dorsal horn, crosses over, heads on up. This is going to have a few stops in the brainstem. That's fine. Here's where we care about the thalamus. Non-painful tactile sensation is going to hit your ventral posterior nuclei. Medial for the head, lateral for the body. Pain also hits there. Pain's going to have a few other targets as well, the medial dorsal nucleus, the interlaminar nuclei. So if you have damage that affects tactile sensation, it damages the ventral posterior nucleus of the thalamus, or just the input to it, you still have these backups for pain. That's why it's not uncommon to have chronic pain following damage to the sensory pathways. Here's the balance. Pain, non-painful, sort of. When you have damage here, your balance gets shifted. That leads to that chronic pain. So that's another common complaint in TBIs. Alterations in consciousness vary. With concussion, you can get a little confusion and drowsiness. You're not fully awake and responsive, but you're not in a coma. Some TBIs that are more severe are going to cause coma. Of course, we've all heard of the classical coma scale. You look at ocular function, motor responses, verbal function. You come up with a little composite score at the end. Max being 15. Anything less than 8, I'm going to tell you, that indicates coma, 8 or less. Now, what causes coma could be widespread damage to the cortex. I'd say that's far less likely, though. Most likely, we're talking about damage right here in the midbrain. It really just has to do with probability. What are the odds that you're going to damage all of this or just that? You're more likely to damage the smaller area more completely than the cortex. Yeah, you'll get some cortical damage, but it needs to be very widespread if you're going to have coma. Alternatively, you can just sever the ascending arousal system as it passes through the midbrain. What you do is put all your eggs in one basket. You collect your axons right there, and axons are a common site of injury. We'll get to that in a bit. Now, the ascending arousal system is this collection of brainstem neurons that project upwards to the thalamus and the cortex and provide general arousal. You're all awake and excited to be here because of this. Coma patients, on the other hand, don't get that excitatory drive from the brainstem due to damage. Damage to the axons as they make their way up. Without cortical activity, there is no consciousness. That makes them unresponsive, unaware of what's going on. So midbrain damage likely to cause coma. Now, if a patient is in a coma, how can you tell the level of damage? Where is it? Is it up here? Is it down the brainstem? You can't ask them, of course. So you have to look at reflexes. There's a variety of reflexes that you can test, and they're going to work their way from the top on down. We're going to start basically in the thalamus, but really looking to see, do we have any signs of increased intracranial pressure? We all remember intracranial pressure. Not a good thing to have elevated. Right. Okay. So you can actually see intracranial pressure by looking in someone's eye. And that's because we have cerebrospinal fluid running in our optic nerve, and what it causes is a little bulging of the optic disc. So by just taking a look in with this ophthalmoscope, you can have a look. Does the optic disc look normal? Or is it starting to kind of look angry and bulged out? This is a clear indicator that we have very high intracranial pressure pushing out that optic disc. So this tells you increased intracranial pressure, something is wrong. The coma would also tell you something is wrong too. You can also look at whether we have damage at the level of the thalamus. Here's just a good old blink to threat. So with their eyes open, just pretend like you're going to poke them. And if their cranial nerves are working, at least the level of the thalamus, and a little midbrain as well, they need the oculomotor nerve as well, they'll blink. You don't actually have to be awake. You can't do it to yourself. You know you're not going to poke yourself. It's got to be someone else. You can also just do this. Don't poke them. Pupillary response. This is going to test essentially the same cranial nerves here. So you shine the light. You have to, of course, be able to see the light. That's cranial nerve 2. And then you have to be able to respond to the light. That's going to be cranial nerve 3. So you should be constriction of pupil, direct, and consensual. So both pupils should constrict. Working on down. Now we're going to see the vestibulo-ocular reflex or the oculocephalic reflex, either way. Have you ever thought about how magical it is that you can move your head around and your eyes stay fixed at whatever you're looking at? Isn't that crazy? The world doesn't just shift around. And that's because we have our 8th cranial nerve here hooked up to our vestibular system. It's working. It's magic. So we have cranial nerves 3, 4, and 6 hooked up to the eyes, and they're getting input from our vestibulocochlear nerve, cranial nerve 8 there. Vestibular is the first part of that nerve. So it senses head movement, and we get a compensatory and opposite movement of the eyes, so we can fix our gaze. For the coma patient, you need to do the rapid turnings that you elicit the reflex. But for us, who are actually here looking at something, you can fix your gaze and look all around, and your eyes will stay fixed. Wonderful. This is kind of like blink to threat. Different cranial nerves, a little gross. So here they just swab the cornea. Patient blinks. That's moving on down and going even further down into the medulla. Here we're going to see the gag reflex. Here we want to see bilateral pharyngeal contraction here, not just one-sided. All right, we're just on from there. So we start up at the top, and we can kind of localize. We have damage midbrain. That would be here. Midbrain and pons. Getting this. Pons. Medulla. So going from top, midbrain. This is thalamus, midbrain, pons, medulla. Of course, if you have medulla damage, very likely to have respiratory issues as well. We'll see those in a second. You can also assess the level of damage by looking at any sort of abnormal posturing if present. Hopefully it's not. These are generally indicators of poor prognosis, especially the cerebral posturing. And that's to do with the level of injury. So this flexor posturing here, this decorticate posturing that we see in A, legs are extended, patient's unresponsive, of course, and there's flexing of the upper limbs. That's because of the intact spinal tract telling you the damage has to be above the level of the midbrain. So we've severed the ascending arousal system, but we haven't severed the descending spinal tract, which biases does anything else besides that, at least in humans. Decerebrate posturing is damage below the midbrain. So now you're down to the pons, medulla. This is where things get bad. Those areas control breathing, swallowing. So when you see this extensor posturing, that's telling you lower damage in the brainstem below the midbrain. This is just saying the spinal reflexes should be intact. If the damage is restricted to the head, as long as you don't have injury to the spinal cord, you can test that, of course, by just looking at spinal reflexes. So they should still respond to pain. Any damage that damages below the midbrain has the possibility of giving you irregular respiration. This is a major problem. The type of respiration that you can see is variable. You can get your Cheyne-Stokes breathing, where you get this oscillation in frequency. There's a pause, burst, pause, burst, pause. Hyperventilation can occur. This can be bad because it'll reduce cerebral blood flow. Just by increasing oxygen levels in the blood, you're going to get vasoconstriction as a result. And then there's apneustic and ataxic breathing. Apneustic is where you have breath holding on inspiration and expiration, and then ataxic is just disorganized. This is suggestive of medulla damage. You may also see Cushing's triad in patients with traumatic brain injury, or really any elevation in intracranial pressure. It doesn't have to be from a TBI. So that increase in intracranial pressure is going to lead to irregular respiration. It could be the damage itself, damaging the medulla, or it could be increased intracranial pressure pushing down on the brainstem. We'll see that in a bit as well. But an increase in intracranial pressure can cause herniation and move around brain matter. And when you move around brain matter onto the pons and medulla, well, then you see abnormal respiration. That irregular respiration or the intracranial pressure itself can decrease cerebral blood flow. If you have hyperventilation, that will contribute to it, but just the intracranial pressure itself will. And we'll see a little equation in a bit, but the amount of blood that makes it into your head has to do with the difference between your arterial pressure and your intracranial pressure. So as you have increased intracranial pressure, it's hard to push blood into the brain. To compensate for this, you'll see hypertension, so irregular respiration, hypertension, and then that hypertension will cause a slowing of the heart rate. That would be Cushing's triad. This is indicative of an increase in intracranial pressure to a dangerous degree. And of course, it indicates poor prognosis. It has many things to do. You can summarize a lot of these, just say degree of damage, particularly in the midbrain. If your amnesia lasts for a longer period of time, that suggests greater damage to the hippocampus. So again, greater damage. Duration of altered consciousness, greater damage. The more severe the damage, the longer you're going to have either confusion or coma. Severity of impaired responsiveness, again, degree of damage. That's what it boils down to. So the more damaging the head injury, the worse it fares. Not too complicated there. The main things to think about, though, brainstem damage, any sort of alterations in breathing or blood pressure control, that's indicative of damage down to the brainstem, so we can put those together. Swelling, and of course, hematoma. These are bad because they increase intracranial pressure. They can herniate brain tissue, as we see here. Here's a little, not so little hematoma, and that's pushing the brain over. So here we see a subpulsing herniation where we're pushing our cingulate across the midline. This is not great. It's better than the others that we're going to see in a bit because it doesn't involve the brainstem. But still, not great. You want to handle that ASAP. Epilepsy, that's indicative of, again, greater damage. Being old, never good, unless we're talking about finances or emotional responses. Other than that, not good. And then a history of brain injury, also not good. Repeated head injuries, as we'll see, can predispose you to widespread neurodegeneration. And patients with psychiatric disorders tend not to do as well. Okay, any questions? Yes?
Hold on, I have a question, and I need to find it.
Okay.
It had to do with how pain is caused, like neuropathic pain. Okay, so this might be a bit of a tangent, but you were talking about like the BPM and how it's balanced by that purple clump. I don't know what its name is. Can you just go over that again really quickly?
Yeah, sure. Okay, so the thalamus has many different nuclei in it, and we will talk about these next semester. The different thalamic nuclei have different inputs and different outputs. So they're going to be hooked up to different parts of the cortex. They're going to receive inputs from different sensory organs. Some will deal with vision, some with audition, others with tactile sensation. It could be non-painful or painful. So the non-painful tactile sensation is going to go down here, ventral posterolateral and ventral posteromedial nuclei, face, body. We have a bunch of maps in our nervous system that are arranged in a way that makes sense. So our visual cortex has a map of our retina, and the relationships are preserved. Same thing here. The relationships between different parts of the body and head are all preserved. So we have a little map of our body in the thalamus right here. Painful and non-painful somatosensory information is going to be relayed to the ventral posterior nuclei. So they both hit there. Now, painful sensation is going to have some offshoots. We can see them down here in the brainstem, also in the thalamus. So multiple thalamic nuclei are going to get input regarding painful stimuli. So damage that affects non-painful sensation, that's going to perturb activity in the ventral posterior thalamus, but we still have these backup nuclei. So pain is still going to affect the function of your nervous system. That pain input is still going to make it. And everything is a relative comparison. So when we're talking about somatosensation, is this painful? Well, no. And that's because I have a greater activation of my tactile, non-painful pathways than my painful pathways. But certainly I'm stimulating my A delta and C fibers. There's no doubt about that. But the comparison, is this painful? Well, no. No. Now, if I were to pinch myself and give it a little bit of time, then it starts to hurt. Or if I were to burn myself or something like that. And that's because I'm going to strongly activate pain-sensing neurons and not as strongly activate my just tactile sensing neurons. So that's the difference out here. What if I were just to damage my balance? So now my balance of pain to non-painful, we'll oversimplify it, that's fine. If this gets damaged, well, I still have my pain-sensing pathways intact. And so the calculation is always biased toward pain. I've lost my non-painful comparison. Make sense?
Yes.
Okay, good. Anything else? Pain matters, and pain is very complicated. But when you have it, it's a problem. Okay. Take a moment, talk about these. We'll go through them, and then we'll talk about the same stuff we've already talked about many times.
No, it's okay. I just don't. There's no derivative damage. Like, I think it's such a long. What symptoms they have?
Yeah, it's like
The big stuff breaks. Most of them, 10 days. Headache. I don't remember.
What is she doing?
All right, does anyone need more time? Okay, thank you. We're going to skip this first one. I just don't want you to read me the last slide. You can just go back to the last slide. That's cool. Common symptoms of concussion, probably useful to know. Rogan.
Yep.
Lay it on me. Let's say I have a concussion.
Yep.
What might I experience?
Headache, dizziness, loss of like motor function, like you don't have actually like I don't know if actually is the right word, but it's more difficult to move or have precision.
Okay. Yeah.
Movements. You could black out, which is not good. Dizziness, nausea, mood changes, mood swings.
Okay. Yeah. Great. There's a variety of different symptoms that can occur. Let's jump down here, actually. Why don't you go ahead and tell me why this matters? Why would I want to take baseline measurements?
You want to take baseline because you want to see how the individual is before injury. So that way you compare post-injury to before injury so you can see if there's any difference.
Yeah, great. Well, why don't I just say, well, I'm not going to ask you that. Let's say I'm a real dumb guy, right? Maybe my memory sucks. And even without a concussion, it's just going to be low. Right? It's always important to have that baseline so you can look at your individual changes. Thanks. Jenna. Martin.
Who went to the bathroom?
Okay. I'm going to have to yell. Well, Courtney. Hi. Okay, so tell me, what's the most likely cause of coma following a traumatic brain injury?
Damage to the midbrain.
Fantastic. Right, you could damage the entire cortex. It's not as likely, though. It's far bigger. So to hit the entire cortex, not as likely. What's that tract that runs through the midbrain? Exactly, the ascending reticular arousal system. Fantastic. So there's neurons in the brain stem that stimulate the cortex and thalamus. Okay. Is there anything that we should review? I got a no. Going once. Thank you. So, all right. Primary and secondary injuries can occur with the TBI. Same thing is true with spinal cord injury as well. We were waiting for you.
Oh, thanks. I appreciate that.
Yeah.
It was Jennifer's fault.
So the primary injury is going to be caused by the actual trauma. But following that, well, we're going to have to clean that mess up. There could be inflammation. That should ring a bell. Probably not the best thing. It's not the worst thing, but it's not benign. Nerve cells respond to inflammation. There could be swelling. What if there's a bleed? God, things could go horribly wrong, even after the trauma. Okay, so that would be the secondary injuries. These are far more prolonged. You have a large window for secondary injuries. The primary injury is just from that physical force that's acting on the head. Now, it could be something like a gunshot wound that causes an open injury. That's what we see here. Use a CT scan. You can see a intracranial bleed here, so here's a little hematoma. It's going to obviously cause problems down the road. And right now, you can see the point of entry, the spreading of shrapnel here, damaging axons, cell bodies. Not every TBI is open. More commonly, they're going to be closed. Usually it's just a fall, bump your head. Those falls, though, they still move the brain around. But they don't move it all equally, and that creates a problem. Different parts of the brain are going to be displaced to a greater degree than others, because the head's going to rotate. That rotation is going to cause diffuse axonal injury. In the case of this type of rotation, it's a little easier to see here. So the center point will kind of stay still. You'll get a little movement. As you move further away, a greater degree of movement. And since we're stretching the outside further than we are more proximal regions to that axis of rotation there, we're going to create shearing forces on these axons. They're going to get pulled and stretched because they're going to be moved a different degree because of the rotation. That's going to cause diffuse axonal injury. Axons are undoubtedly the most common site of injury. They're longer than the cell body, so they cover a much greater distance, so they're more likely to be damaged. They're very, very thin. And when you have rotation of the head, that's what's going to create shearing forces and rip those axons apart. I want to make sure this makes sense. And we should keep in mind that there's the injury itself, and then there's the bouncing back from the injury. So let's say here's our skull. I don't know. You get the point. So in a head injury, let's say here's our steering wheel. We bump into the steering wheel there. Now we'll give it some eyes. Okay. So you have your initial injury, where you bump. Of course, after that forward motion, then the brain's going to bounce back. And I can't really draw that, but it's going to hit back here. We're also rotating. Usually we have a neck down here, so we're going to rotate. Now that point of rotation down here means that as you move away from it, you're going to get a greater degree of displacement. So the axons, as you move further away from that point of rotation, are going to be stretched further than those that are closer. So when you think about the degree of displacement, if we have our point of rotation here, here is some distance away, the displacement increases. So we're going to be stretching axons further as they're further away from that point of rotation. That is what the shearing force is that they talk about in the textbook. So if my cell body is up here, tight, this is going to be displaced heavily while this stays still. The distance here is, of course, greater than this. Hopefully we remember our geometry. So we're stretching that axon. This is not a rubber band. It's going to break. So that's going to cause our diffuse axonal injury there. Not every axon will break, but many of them will. As we see here. You can estimate where axons are located because they're usually myelinated, and that myelin is fatty. It restricts the movement of water, so you can just track the movement of water using, I mentioned, diffusion tensor imaging. It's not written here. That's what it is. It's an MRI method that looks at the movement of water. As you sever your axons, you're no longer restricting diffusion of that water anymore. And so what we can see is following head injury, there are areas where axons disappear. We should have axons coming out of the entirety of our corpus callosum here. That's what this is showing you. So this is front, back of the brain. Here's the midline. Here's that center, that white matter, corpus callosum that's radiating out into the cortex. All over. Following a head injury, we have axonal damage. Axons cover greater distances. They are thus prone to those shearing forces, and they're also very, very thin and delicate. Once you sever an axon, it's going to degenerate anterogradely. So that's the Wallerian degeneration there. So from the site of injury on down, away from the cell body, all that axon dies because it can't make proteins. you've severed its source of protein. And a cell without protein is not really a cell now, is it? So all that leftover axon past the site of injury is gone. And as we'll see on Wednesday, axons don't grow well in the central nervous system after development is complete. So those severed axons are just done. That's it. Very little functional recovery. Peripheral nerve damage, not great, but you can get some functional recovery. Peripheral nerves can regrow. Nerves within the central nervous system, no, not going to happen. But I don't want to get ahead of it. We'll talk about this more on Wednesday. But diffuse axonal injury, very common in TBIs. So you get widespread damage because of really rotation of the head. Now, after that injury, then comes the cleanup. Now, the injury itself could increase intracranial pressure. Here we can see a fairly large hematoma pushing over. Here's the midline, by the way. So that corpus callosum should be over here. This lateral ventricle should be over here. Everything's been pushed over. That's caused by the actual bleed itself. But any increase in intracranial pressure, whether it's from that or the inflammation, which is, of course, going to be related to the severity of injury, the greater the degree of injury, the greater the degree of inflammation, the greater the degree of swelling. Our central nervous system can only compensate for this for so long. So a lot of this brain tissue, we have some extracellular fluid, we can displace some of that. So as we get a lesion, it's okay until it's not. As the lesion volume increases, there's a nonlinear relationship with intracranial pressure. That's because we can push out some of the fluid, so we can get rid of a greater degree of CSF. We can let a little less blood in, that's fine. Not ideal. But once we exhaust our compensatory mechanisms, then it's off to the races. And any increase in intracranial pressure beyond about 20 millimeters of mercury is going to require some intervention. That's when things get serious. You run the risk of herniating, compressing the brainstem, and having respiratory failure. Which is a nice lighthearted topic, really. I can see why I'm laughing. Now, the degree of blood flow that goes to the brain is going to depend on your mean arterial pressure and your intracranial pressure. So a drop in peripheral blood pressure is going to be dangerous because that's going to decrease the amount of blood you're getting to your brain. And an increase in intracranial pressure is going to be dangerous. That's going to decrease the amount of blood you're getting into your brain. So it is important to control peripheral blood pressure. You might need to increase that to force blood in. Another reason why we're going to have alterations in cerebral blood flow is actually damage to the vascular epithelium itself. So the blood vessels are responsive. They're not just passive. They respond to the degree of neuronal activity. If an area has an increase in activity, they open up, bring in more blood. Normally this is accomplished by producing nitric oxide, but following an injury, vascular epithelial cells no longer produce nitric oxide immediately following that injury. As a result, you lose your vasodilator, the nitric oxide, and that leads to vasoconstriction. So you get a shrinking of the blood vessels, an increase in intracranial pressure, and both of those together are going to decrease cerebral blood flow. You get ischemia. You have the risk of ischemia here. That's still bad. It still causes ATP depletion, leads to excitotoxicity. Nothing new. That head injury itself, everything is mechanically gated to some degree. So when you smash the head against the skull, if those neurons survive, they're going to be excited. That mechanical stimulation could cause excitotoxicity. And then, of course, afterward, during the cleanup, inflammation can cause reactive gliosis that impairs potassium uptake and glutamate uptake, leading to excitotoxicity. See essentially every lecture before now. Same stuff, nothing new here. As we have increases in intracranial pressure, then we have the risk of herniation. What we've seen thus far would be this subfalcine herniation, where the cingulate gyrus gets pushed over across the midline. This has really nothing to do with breathing, so we're usually fine there. This is not going to be lethal. The lethal ones are going to be down here. So it could be a central herniation pushing down on the midbrain. That compresses the brain stem. Here's your respiratory centers. It could be uncal herniation, not related to ant herniation. This is where the uncus of the temporal lobes gets pushed downward and compresses the brainstem. And then tonsillar herniations, where the little, what we call the tonsils of the cerebellum get pushed downward, again, compressing the brainstem. This is when things get bad. This is when you have respiratory issues. Remember, poor prognosis when you have a greater degree of brainstem damage. Herniation can cause that. This up here, not so bad. These are terrible. And repeated head injuries are never a good thing. Even mild head injuries, even repetitive mild head injuries can lead to widespread neurodegeneration. They essentially create a trauma-induced form of Alzheimer's disease. It looks a whole lot like it. Chronic traumatic encephalopathy is what it's called. But it looks very similar to Alzheimer's. Risk factors are similar. That ApoE4 allele, still not good. This increases your risk of CTE. You see A beta plaques, just like you do in Alzheimer's disease. You'll see that in CTE patients. And the causative factor for neuron death, neurofibrillary tangles. We see tau abnormalities. This is a trauma-induced form of Alzheimer's. You're seeing A beta plaques, tau neurofibrillary tangles, and widespread cortical degeneration. This is caused by repeated head injury. So it's going to be restricted to the areas that are getting bumped around and damaged. It's not going to be as widespread as Alzheimer's, but it will progress. Likely that has to do with the sort of prion-like behavior of tau. Anyway, not a good thing. Do we have any questions? I got a no. I'll take that. Okay. All right, we have -1 minute. So go back in time, talk about these, and then we'll get that on Wednesday.